I'm a genetic counselor and professor at The Ohio State University, and I'm so honored to be here to join this session, to be here with Dr. Sarkozy and Dr. Hackman to share some information about Titin and learn together. I have the task of kind of setting the table and introducing the basics about Titin genetics and genetic testing. And I can see, just looking out at this audience, that we already have a lot of expertise in this area. So I hope that you learn something from this, fairly basic intro. So what I hope to do is introduce titinopathies and how they run in families, discuss key aspects of genetic testing, and then summarize some take-home messages for families. What are the key things that we can learn from genetic testing, and what are the challenges that we can face with genetic testing? And then I'll turn it over to Dr. Sarkozy and Dr. Hackman, who will give us much more detail about these concepts. So titinopathies are genetic conditions affecting muscle. And this includes various muscles in the body, the muscles used in movement, which we call the skeletal muscle, the muscle in the heart, which is the cardiac muscle, and also muscles used in breathing. So even though these body systems might seem to be different, the common denominator here is that these are muscle tissues. And many different titinopathies are named for their symptoms, how they present, the pattern of weakness they might have, sometimes for pathologic findings that we might see on muscle biopsy. We also sometimes include in the names how these conditions run in families. And being a genetic counselor, of course, I view the world through a genetics lens, and I like to divide the Titin conditions into dominant ones and recessive ones. So on the left-hand side, Titin-related dilated cardiomyopathy is probably the most widely known and diagnosed titinopathy that we have. We also have Tibial Muscular Dystrophy, which was the first skeletal muscle titinopathy identified by Dr. Hackman, who's here to tell us more about it. There's also a condition called hereditary myopathy with early respiratory failure, or HMIRF, that's dominant. And then there's a few additional cardiac dominant conditions which might get lumped into cardiomyopathy. Some people might consider them separate. And then we're learning that there are some new dominant titinopathies as well, which can affect both the skeletal muscle and the heart, that they don't really have their own category yet. On the recessive side, it's an even longer list, and this is not an exhaustive list that I have here, but we have the sort of homozygous or compound het version of the tibial muscular dystrophy, if you have two copies of that genetic change that causes limb-girdle type 2J or R10. There's also a long list of different congenital myopathies that can be caused by recessive Titin mutations. And I'm not going to talk about those conditions very much, and hopefully Dr. Sarkozy can fill us in a little bit, or you'll hear more as the conference goes on. In the headline news, we have a new very interesting titinopathy, which is the digenic titinopathy that was just reported last year. And digenic is a genetics term that means you actually have to have genetic changes in two different independent genes. And this is a very unusual genetic mechanism. There are very few conditions that have digenic inheritance. So for a genetics person, this is pretty exciting. But this group identified males with both truncating variants in Titin, as well as mutations in this other gene called SRPK3. And this is a gene that previously was known as an intellectual disability gene, but for males who have both of those genetic hits, so to speak, they have this new condition which has digenic inheritance, which is very unique. And I understand that there's a poster on this condition at this meeting, so I'm really looking forward to seeing that poster and learning more about this. The initial paper focused a lot on that digenic mechanism, so I'm really excited to hear more about the phenotype. Yes, Sarah?
Sorry to interrupt you, but I did want to mention that our posters are actually on that computer there, so they can't
Perfect. We can have an intermission where we check we all can go to the poster and look at it together. That's perfect. However, that being said, most titinopathies are dominant or recessive. And dominant simply means that it only takes one genetic change to cause symptoms. And dominant inheritance is characterized by generational transmission. So we call that vertical transmission, so parent to child to grandchild. And that's something that we look for in family histories. If we see previous generations affected, that could indicate dominant inheritance. Now, recessive means that it takes two genes, one from mother and one from father, who usually are not affected, and that double dose in the child can cause the condition. So, for example, as I mentioned, congenital muscular dystrophies that are caused by Titin tend to be recessive. Now, we can spend a lot of time, in some cases, trying to find out if someone might have a dominant or recessive titinopathy. There are some general rules of thumb. Typically, if you have congenital or early onset of symptoms and a Titin condition, those are usually recessive. If you have milder, late onset, slowly progressive symptoms, those might be dominant. Now, there are some exceptions to this, but in general, if we see early onset, we think recessive, even if the genetic test doesn't initially point in that direction. And I'm not going to actually show the diagram for what the digenic inheritance would look like because it's pretty complicated. But what we look for in families would be the presence of affected brothers for that digenic inheritance. So what is Titin? Titin is actually the largest protein in our body, and like all proteins, it's genetically encoded with its own genetic recipe. And this giant protein is present in our muscles to give them strength and springiness, and allows us to generate immense strength with our muscles. And one of the amazing, unique, wonderful things about Titin is that different versions called isoforms exist in different muscles and also at different time points in the human lifespan. So one of the things that we think about when we're trying to determine if a given change might be harmful or not is it actually made into a protein, and when is it actually made into a protein? And that's one of the many ways, one of the many clues that we can get as to whether or not a given genetic change might actually be impacting muscle function. So I alluded to the fact that it's problems with this genetic recipe that cause titinopathies. And the gene is made up of 363 coding units called exons. We call that the metatranscript. It's kind of our map of the gene. And those different exons are stitched together in different ways in different muscles and also at different time points in life, as I mentioned, to provide the functional Titin protein that's in our skeletal muscle, our heart, and all throughout the muscles of our body. But if there's a harmful change, that can mean that the body cannot read that message that's encoded by the gene, and the protein that results is either not made to the right quantity, or there might be a bend or something about it is not working such that it is not functioning normally in the muscle. And in some cases, if there's just one protein, it might actually interact with the protein that's made from the normal copy of the gene to create additional problems. But these genetic changes are typically inherited from parents, and they can be passed on to children. And the risk of those children being affected really depends on if the condition is a dominant titinopathy or a recessive titinopathy. So that's one of the reasons why it's so important to sort those questions out. So we're studying right now what different combinations of genetic changes might cause different titinopathies. And this is a picture just of the M band, which is the very, very end of the Titin gene and protein. And we're starting to learn that we can sometimes see patterns between the specific genetic changes that might be present and the condition that results. This is hard though because there's some Titin changes, for example, the ones that cause a truncation or a stopping of the protein production that can be seen in many different kinds of titinopathies. So although we're working on this, it's a real challenge, but there's a lot of different combinations, and ways that it can pan out. So genetic testing is really important in titinopathies, and I'm going to talk about two types of genetic testing. One is diagnostic testing. This is the type of testing that many people in this room have probably had, a test to find out what is the cause of the muscle weakness or the cardiac symptoms that you might be experiencing. And typically, this might involve a multi-gene panel test. This is commonly used in adult clinics where we'll take a blood sample and we'll look at, say, 200 different genes that can cause muscle weakness or muscular dystrophies of some kind. We can also do whole exome or whole genome sequencing, and these are technologies where we try to test every gene in the body. And you can imagine how difficult that is. But for whole exome sequencing, for example, we try to look at every gene in the body that codes for a protein. These tests are more commonly used in pediatrics, but especially for titinopathies, they tend to be better at capturing the big picture. Many times they will also look at parents, and we can compare parents' variants to children's variants. Many times the laboratories will incorporate clinical history, symptoms. So it's a better test if you have access to it to get that whole exome sequencing, but it's not always available. And in that case, a panel test may be enough to get us there. I'm also going to talk quickly about reproductive genetic testing. This is something that Sarah requested, and I'm not a reproductive genetic counselor, but I'm happy to share with you a little bit about this technology. But this involves testing of prospective parents to determine or avoid risk in a pregnancy. We can also do pre-implantation genetic testing or genetic testing of a fetus in utero. So I'll talk quickly about that at the end, and just someone let me know if I'm running out of time. So diagnostic genetic testing is really important to help us achieve that etiologic diagnosis. So what that means is we want to understand what is the genetic basis of this condition. And this is tight. I heard someone mentioning earlier as we were sitting down, titinopathies can have so many different phenotypic presentations. The symptoms can be so diverse. How can we make a specific diagnosis on the basis of these overlapping and yet different symptoms? So genetic testing is really necessary to actually get a titinopathy diagnosis. Ideally, it's done as part of a specialist evaluation that includes physical examination, special studies such as echocardiograms or EMGs. That's an electrical diagnostic test of the muscle where we stimulate the muscle electrically to see how it might respond. Muscle biopsy, taking a piece of muscle to look at it under the microscope. Muscle imaging, things like ultrasound or MRI can be very important, especially in titinopathies, as I'm sure Dr. Sarkozy will tell us about. And lab tests such as looking at CK levels, for example, and also review of the family history. And of all these things, I would say review of the family history is probably the most overlooked item on the list of things that we can learn about to get more information. So I just wanted to share that in the United States, there is a free test that's available for anyone who has muscle weakness that is sponsored by the Muscular Dystrophy Association and Sarepta, and this is offered by the Invitae lab, and it's free for any healthcare provider to order. So this is a nice resource that's currently available to us here in the United States. So getting that genetic diagnosis is really important, and I keep talking about that, but I just wanted to hammer home that not only does it provide us with an explanation of what happened, it can sometimes enable us to provide specific medical management that we might not otherwise know to do. And in titinopathies, that can be very important, for example, to look at the heart and heart function, because people can have significant impairment in their heart function before ever having any significant symptoms. So it's really important when someone has a titinopathy, whether or not it's known to cause cardiac symptoms or not, to consider whether echocardiogram or other cardiac surveillance might be needed. And I think Dr. Sarkozy would tell us more about that too. But in addition to those things, it also allows us to test family members and determine what their risk might be to be affected or to have a child who might be affected. It sometimes enables us to do some of those reproductive options that I'm going to tell you about in a few minutes. It can open doors to research and clinical trials, and in general can empower families with knowledge and a community like the community we have here today. So genetic testing is really the first step to this genetic diagnosis, but it's not always easy. Before I talk about kind of the challenges of genetic testing, I wanted to take a step aside and just talk a little bit more about that family history. And this, as a genetic counselor, is something that genetic counselors are trained to take detailed family histories and sit down and really take like 20 or 25 minutes to go through a family history. That doesn't always happen in busy clinics when there's a lot of things to talk about. But for anyone who's concerned that they might have a titinopathy or really any muscular dystrophy, think about your family members, think about your relatives. Is there anyone else in the family who has muscle weakness, muscle pain or fatigue, loss of muscle, high CK contractures, any kind of muscular dystrophy diagnosis, any cardiac symptoms, everything from an enlarged heart, abnormal heart rhythms, to cardiac transplant, or congenital heart defects, like a hole in the heart, for example. Also, breathing symptoms can be important to learn about: respiratory failure, shortness of breath, difficulty breathing at night. So even if your doctor doesn't ask about these things, think about your own family, person by person, and if you have any family history of these things, report that to your medical team so they can take that into consideration. So interpreting the genetic test is sometimes the tricky part. Genetic testing is complicated because we all have genetic variants in our genetic code that will be picked up by these tests, whether that's a whole exome test or a panel. And when the laboratories are reading through the sequence, they will pick out the variants that are rare, and it's then their challenge and their job to say which of these variants might be actually causing disease and which ones might be harmless. That distinction is not always easy. And there's some judgment calls that come down to, like, are we going to report this variant, and are we going to say that it's uncertain significance, pathogenic, or benign? And in general, in clinical genetic testing, there's 3 categories of results. There's positive, meaning we found a genetic change that we believe can cause disease. Negative means there was no harmful variants found, and uncertain means that one or more variants was found that we don't have very much data about. And these variants tend to be rare variants that get classified as being of uncertain significance. And that's a real challenge across all of medical genetics, but it's especially challenging in Titin because it is such a large gene, and we don't have as much history going back to know about what's the spectrum of genetic change. We've only been able to sequence through this large gene, practically speaking, for about 10 years. And Dr. Hackman can tell you about how much work it was just to find the first TMD mutation in his Finnish families. So it's a huge gene, and before we had certain technologies, it was really impossible, except for people like Dr. Hackman, to even go through that gene. But many variants of uncertain significance are not harmful and don't establish a diagnosis of titinopathy. So these variants have to be approached with caution, and we're going to hear more from our other experts about the things we can do. But basically, there are some additional things that can be done. Genetic testing of parents can be very important to determine which variants were inherited from which parent. And in recessive conditions, we need both parents to contribute a harmful variant. It's also important to search the literature and online databases where we collect information on rare variants. Sometimes we need to go back to the individual and say, well, has this person had a muscle imaging or muscle MRI? Can we do that to learn more about the pattern of weakness? Sometimes we need to do updated or additional genetic testing. This is not uncommon. And sometimes we might need to turn to research techniques such as RNA studies to try and get more information about how that specific genetic change might impact muscle function. But it's really important to ask questions and be cautious. And I hate to say it, but sometimes we can't actually take the genetic test at face value. We sometimes have to do a little bit more digging and thinking. So this is just one example of a genetic testing report. And here what we're looking for, first of all, is are there any variants that are pathogenic or likely pathogenic? And here we have a pathogenic variant that's listed right at the top. So this is a truncating variant that happens to be in the M band, and there's a second variant there that's listed as uncertain significance. Both of those are in Titin. So anytime we see a variant of uncertain significance teamed up with a pathogenic variant in the same gene, that should get our attention to think, could this be, could we learn about this particular combination, and could this be important? But in addition, there's all of these, additional variants of uncertain significance as well. So, for someone who's not used to ordering genetic testing, for a family, this can be quite overwhelming to look at this list and say, what does this mean? But that's where, the additional digging and, in some cases, testing of family members, testing of the affected person can give us more information. This particular individual was one of the first that I met when I started in the MDA clinic where I work, and he was a young man with distal myopathy. And the first time I met him was about 10 years ago. I ordered a multi-gene panel for him, and it came back with just that DNA JB6 variant. That was it. And then I was like, well, I don't think that's the cause, but I later, about a year later, I ordered exome sequencing for him, and it identified these 2 Titin variants. And this was the same lab where I had sent the neuromuscular panel. So I said, why didn't you tell me about the Titin variants when I sent the panel? And they said, well, we thought that they were cardiac variants and your patient had muscle weakness, so we're not going to include that. We didn't think that mattered. And so to make a long story short, right about the same time that we had sent that exome sequencing, a report came out about Titin-related distal myopathy, and his presentation fit exactly with that. And had we stopped at that neuromuscular panel and not done the exome sequencing, we would have missed that. And then several years later, I sent a new test on him, mainly because I wanted to test family members. And this is the report here. And one of these 2 variants is called uncertain significance, but it actually affects an amino acid position that has been seen in a patient with tibial muscular dystrophy. So it's a slightly different missense change, but it's the same position. But the bottom line is this lab is very conservative about how they're calling missense variants. And even though we're very suspicious that this, this missense change is behind it, this lab is not going to change the report. And even though I think this gives us a recessive, we think this is our diagnosis, it's very satisfying, it fits, the genetic test still doesn't match up with our genetic diagnosis. And this is not uncommon. So I just wanted to point out that when you do get your genetic test report back, it does contain a lot of information, and it's important to go through that. There's information that talks about other reports of this, whether those are publications or in online databases. And these are resources that your physicians and your medical team can use. These reports are long. They tend to be 7-8 pages long, but they contain a lot of information, and it's not the family's job necessarily to interpret, but you can advocate for yourself by asking questions, by being persistent and asking, is there anything new? What further can we do? So to summarize, take-homes about genetic test results, important things to know. Does this result explain my symptoms or my child's symptoms? Basic, does this explain what's going on with us? Does it provide us with a genetic diagnosis? And if the answer is yes, what's the name of the condition? How is it inherited? What medical care do I or my child need? And who else in the family should consider genetic testing? What medical care do my family members need? So these are all important things to ask and persistently ask. If the answer is no, or not sure, that's okay. First of all, it's nice to have a medical team that's transparent and says that they don't have the answer or that they need further time to find an answer. That's totally okay. We're all learning together, as I always say. But does the result provide any clues that we can follow? For example, if there's one Titin pathogenic variant and we suspect a recessive, what more can we do to look for that second one? How can we investigate variants of uncertain significance? Dr. Hackman is going to tell us more about that. And also, will testing of family members provide useful information? In many cases, testing of family members can be important, and it's sometimes an overlooked tool because the medical team can't control what the family members do. So that burden often falls on the person who's getting tested to reach out to their family members. Well, I really need you to help me sort out this result. So that is something that our hands are tied on the medical team side sometimes, but the family members can really do a lot in some cases. And then, are there any other tests or studies that we should consider clinically or otherwise? So with that, I'm going to change gears a little bit and talk about pre-implantation genetic testing. How am I doing for time? Am I okay?
You're a little over.
Okay, all right. So I'll quickly speed through this then. Pre-implantation genetic testing is only possible if we have an established genetic diagnosis, and that's really, really important. We need to understand which variants are responsible for the condition and what the inheritance is. So I can't emphasize that enough. But basically, pre-implantation genetic diagnosis involves harvesting eggs from the woman, doing artificial insemination with sperm from the man, and then letting those embryos develop to the 7 or 6 day stage where they're actually biopsied. And believe it or not, from those cells, we can look at we can do some genetic testing. Often this is indirect genetic testing. We're not directly looking for the Titin change or whatever it is. We have to look at the background where that gene sits. And for that reason, we sometimes need grandparents or other family members to help us sort out who's got what in terms of the genetics. But because half of all embryos have abnormal chromosomes, we also test chromosomes. And Sarah provided me with a paper from a Chinese study where they had a cohort of several couples with various neuromuscular conditions. And of all the embryos they created, only 10% had normal chromosomes and did not have either of the mutations they were looking for. So that's just a kind of a reminder that just because we go through this, it doesn't mean that we're necessarily going to get embryos that don't have the condition of interest and who also have normal chromosomes. However, typically we could get many, many, many embryos, and in this paper they were able to achieve pregnancies with the healthy embryos. And once you actually get to implanting a healthy embryo and a healthy uterus, the chance of that taking is about 70%. So those types of IVF procedures have very high success rates in the right hands. So take-home messages include: seek a genetic diagnosis, be persistent about it, ask questions about it, and get a copy of your testing report. And if there's any updates, those would often get sent to your doctor. So ask, have there been any updates about my genetic testing report? Have you received an amended report? And then, as I mentioned, we're all learning together, so we all need to be humble and accept that even if we may think we have a diagnosis, it could be refined in the future, or new information could come to light that could change that diagnosis. So I apologize for going over time, and I'll sit down. A physician or a nurse practitioner who's willing to work with her in ordering the test. Okay. Any provider with an NPI number can order this testing, and many might be reluctant because they don't have the expertise. Yeah, so, I would recommend that person seek out a genetic counselor or a geneticist, and genetic counselors are used to ordering this kind of testing, and you can go to nsgc.org to find one.
What was that again?
nsgc.org.
nsgc.org.
Yes.
Because
Yeah, well, this test, you can even order it remotely, and I realize that not all, providers would be comfortable with that, but you can literally, get a testing kit at home and do a saliva sample at home. So that part of it is easy, but it's not always easy to find a practitioner or a doctor that is willing to do that. But in terms of the cost, that part, at least for now, is surmountable with that sponsored test that we have currently.
People that uses and that not use that just their own sports and stuff, they're all concerned about the heart, so I want to get tested for sure.
Okay, so should we turn it over to Dr. Sarkozy?
Yeah. So thank you again for the invitation. And I'm Anna Sarkozy. I work at the Dubowitz Center in London, the UK. I'm a clinician. We see children with early onset muscle condition. In my previous life, I was also an adult working with adult patients with titinopathy. So I will give you an overview of how to approach clinical diagnosis of titinopathies, focusing mostly on those forms that present usually with a recessive inheritance that could present mostly in childhood, but also later in life. So we will go overview these aspects. So you already heard that there are two main categories: the recessive, that usually early onset, and the adult dominant forms of titinopathies. And sorry, I'm not sure what's happening, but there is usually a sort of a generic distinction. What are typical features of people who present in childhood and children? Not sure why is this doing this, because I didn't have animation here. Sorry, apologies. So there are some main features that perhaps are more common in the childhood onset titinopathies and less common in the adult onset dominant titinopathies. So just in general, we often see that children with the recessive forms might be floppy at birth, so we say hypotonic. They might have delay in sitting. So I indicated here that, for example, I don't know, is there an arrow here? Is there another arrow? The green arrow, no. Anyway, so that, for example, there is a bit of delay in the sitting and the walking compared to what you would expect in the normal development of a child. There might be feeding, breathing involvement, and sometimes cardiac involvement, not in everybody. And in the adults, you see that maybe the first steps of life are normal, in the sense normal achievement of motor milestones, and then later in life you might have muscle weakness and breathing, and sometimes heart as well. But there is often this distinction, but unfortunately, it's a little bit more complicated than that. Clearly, you will need care for all these aspects, and care usually involves several steps, and there is really a push towards standards of care to be set up for all congenital myopathies and muscular dystrophies and adult onset conditions that really involve a multidisciplinary care that is really around the patient. So you start from diagnosis, and then you have aspects of rehabilitation, orthopedics, cardiac, and so on. And all these inputs in the multidisciplinary care of the patient has to be aligned with the disease progression. So, for example, if you have a condition that usually does not have involvement of breathing muscles in early age, perhaps you can focus less on that aspect and maybe focus on this aspect later in life when that problem is more relevant. So really the input has to be aligned with when the problems start. However, the most important thing is that diagnosis is really key. And it's very important that you have the right diagnosis, coming back to what you were saying before, because if you have the wrong diagnosis, you might not get the right care for your condition. So insisting on the right diagnosis is very, very important. And it has to be a molecular diagnosis wherever possible in order to be able to do all the steps of genetic counseling and prenatal testing, but also because wherever we will be in a situation of having clinical trials, many of the therapies might be gene specific, so you really want to know which one is your mutation to be able to access those therapies wherever available. Okay, so until a few years back, when we had the patients with a possible myopathy or muscular dystrophy, we didn't have next generation sequencing, so the clinician really had to work a little bit harder. And what we called phenotype down. So you looked at the patient, looked at the features, at the symptoms, at the problems and the signs that the person had, looked at the family history, and then you went like a filter. You did investigation, a lot of tests. So you had imaging, you had clinical investigation, you often had to have a muscle biopsy, a pathology test, and then you went to the genetics because we were not able to do a high throughput genetic testing. So I am really not sure what's happening. It's going all on its own. I'm not pushing anything. All right, sorry about that. I might maybe leave that because there was no animation in here, so I'm not sure why. I will try to go from here. If I hold that, maybe it's just sensor.
See,
Okay.
somebody else may be on our same.
Oh, that happened in another conference. It was the,
Yeah.
it was the other room.
The thingy?
The other room is advancing.
It's getting signals from the other room.
Oh, right, okay. That's fine. I will just use, yeah, that's fine. No, it's all right. All right. So really, before we arrived to do genetic testing, there were a lot of steps that people had to have, and because we were doing gene by gene, it also took a very long time before actually you had a diagnosis. But however, having these steps really gave you different layers of diagnosis. You could have a clinical diagnosis. So for example, you looked at the symptom and sign of a patient, you had looked at the CK levels. So you said, okay, this is an early onset, it's not dystrophic, the CK is normal, it's a myopathy. Then you looked imaging, you did the EMG, there was no nerve involvement, so the nerves were, and then you had a clinical diagnosis. Then you looked at the biopsy and you had a pathological diagnosis. You may have said it's a myopathy with central nuclei or with cores, mini cores. And then all these names probably came along the line and you heard these names and you were told that you had a central nuclear myopathy. And then you had the genetic, and that's Titin. So all of these were right. So all of these diagnoses are correct, are not wrong. But nowadays, we probably have shifted a little bit this diagram, and we go a little bit in a different way. So, and when you have a suspicion of titinopathy, you try to skip the loops and go direct for genetic. Now, it is still not that straightforward, and I try to summarize things with this little diagram. Don't worry, we will review this and try to understand how you go from your suspicion to your confirmed diagnosis that has all these clinical and genetic steps in it. So, first of all, when is the situation where you think that a person can have a suspicion of a titinopathy, and in particular of a recessive form of titinopathy? Unfortunately, there isn't a unique presentation, and you might look around the room and you might think, okay, well, there are different, people may have different problems and symptoms in age at onset, so it's really very different. Sometimes the problems were even present before life, before birth, and sometimes are present in childhood, sometimes later in life. And also, it is also quite obvious now, and looking at publications of people who had titinopathies, that the symptoms in early age can be very variable, how that person will present later in life. And also, within the same families, you may have people who have a symptom at birth, and one type of symptom, and then maybe the family member, even siblings, may be very different. Sometimes even twins can be different, because once we're born, we are exposed also to environmental situation, and variability can be very common. So I will just show you some of the symptoms that people may have. Again, this is very variable. So you might have not had any of these symptoms, or your family member who has a condition may not have these problems. Again, it doesn't have to happen to everybody. It's very variable. So sometimes children may, when they're born, they may have reduced movement in the womb. So moms might feel that they felt the baby not moving that much. And sometimes when you do investigation, you might see that there are tightness in the joints, and the ultrasound, the sonographer might see that the limbs are tight and they're not moving that much. Babies, when they're born, might be floppy a little bit, like flaccid at birth, and they might have tightness in their fingers or in the feet. Again, not everybody may have that. Sometimes may have tightness of other joints as well, or many joints, and what we call arthrogryposis. Sometimes you may have fractures. With progressing with age, you might notice weakness in other muscles. Often the muscles are weak around the neck, the proximal, the shoulders, and the hip girdles. Often the face muscles can be affected, and not in everybody. Sometimes you might see a little bit of droopiness of the eyelids, so the difficulty in closing the eyes. And sometimes you might have weakness also distally in the feet, and you might have foot drop. And then you may have also problems with the spine. You might have a bit of curve in the spine, what we call scoliosis, stiffness of the spine, the rigidity. You can't really bend the spine as well. sorry, that wasn't down on the floor. And then sometimes you may have what we call chest deformity. So you might have a little bit of going inside, like in this picture, the little girl, that the chest may go a little bit in. So these are all symptoms and signs of the condition. And then again, the last picture, you can see the tightness in the joints and the spine tightness. And yes, heart can also be affected in these conditions. So you may have sometimes problems at birth with structural changes in the heart, how the structure of the heart is built up, and sometimes with the function of the heart that can happen also later in life, breathing difficulties, and difficulties with feeding, with gaining weight. Sometimes you may in the session this morning about nutrition, and that is an important aspect also for people with titinopathy. So if you think that the person might have a myopathy or a muscular dystrophy, you want to understand what are the problems that are associated to, still to identify the difficulties. So you really want to screen for these things, because if you don't look for heart problems, investigation. You have to do an ultrasound of your heart and ECG. You want to, and if it's negative when you are 5 or 10 years old, that might change in future, so you want to repeat that. And if you remain undiagnosed genetically, continue to do the investigation, because maybe the heart problem may be picked up later on. It's important for prophylaxis. You want to, catch it as early as possible. Breathing, again, often we don't realize that our muscles are underperforming. The breathing muscles are not as strong, so you need to check your breathing muscles. And that can, again, help you to understand if this could be maybe a titinopathy. So you want to check the breathing muscles, do sleep studies, spirometry, pulmonary function test. You want to monitor the breathing, the feeding, want to see how you're putting weight on, a plot on the chart, your weight, and understand if the child or the affected person would have any issues with putting weight on, dysphagia, like problem swallowing, maybe food going in the wrong way, and then doing X-ray and other investigation for your joints. And the main two investigations that we do routinely in clinic is the creatine kinase level that can be variable in people with titinopathy. It could be either normal or mildly elevated. Some forms can be a little bit higher, but probably is more in the lower end. So usually it's either normal or mildly elevated. And then sometimes we still do an EMG that usually is myopathic. It's an electric test to see how is the conduction of the nerves and how is the response of in the muscle, and usually it's myopathic. But the two other things clinically, without stepping a bit forward to genetics, that are very helpful, which is not invasive because it doesn't hurt and doesn't give radiation at all, is doing a muscle ultrasound or a muscle MRI. And this technique can really give us a very good idea of the pattern of muscle involvement, and can help a clinician who's a bit more expert of this condition to say, yes, that involvement of the muscles, which is like in these little pictures down here, you can see the different colors reflect how the muscles are affected, if you are more affected or less affected inside your leg muscles. That can really give you a clue. This type of muscle changes is typical for titinopathy and can help you to validate your suspicion, okay? So if you do all this investigation and you feel that this looks like the history is correct, the genetic, the family structure is right, the clinical investigations are right, it looks like titinopathy, doing genetic testing. It's important to remember that some other condition can look like a myopathy, but may be missed by this panel testing. So as we always remind clinicians that think about conditions that could be missed, but that anyway, just to remember that. And then you usually go for genetic testing, as you heard, so you do a panel test, and then you can find your diagnosis. If your diagnosis is confirmed at this point, you might not need other tests. So if you find 1 or 2 mutations that are obviously in keeping with your diagnosis, that's fine, and then you don't have to go forward. But sometimes the first line of testing that you did, maybe a panel testing, may not be conclusive. So you want suspicion that this is a titinopathy. And nowadays, at that point, a biopsy can be helpful. So you don't have to have a biopsy if your genetic testing is unequivocally telling you it's a titinopathy, but biopsy can be necessary when your answer is unclear. And the biopsy can tell you a lot, can tell you if there are changes in the biopsy that show that there's a myopathy or a muscular dystrophy, and can tell you if there are specific changes like central nuclei or mini-cores or multi-mini-cores that are visible in specific staining that is very typical of titinopathy. It's not a genetic diagnosis, but can help to tell you that there's a right suspicion for that condition. And also because a biopsy can help you to give you tissue for further tests that you might have to have, or the person with titinopathy may need to have to find a mutation. So we heard about DNA testing, but sometimes you need to have RNA testing, and the RNA that we need to study has to come from the muscle, wherever possible. So that's also why you want to, it's useful to have RNA muscle. Muscle biopsy, however, particularly in children, is quite invasive. You need to have a general anesthetic, so we don't do it like, without really an indication. But there are reasons why it might be good to have a biopsy. And I wanted to mention that the other recessive titinopathies, they might have an onset often more, later in life, and they have been recognized with different names, and they are not called just congenital myopathies, might be known as recessive distal myopathy, or limb-girdle muscular dystrophy titinopathies, or there is also a so-called Emery-Dreifuss muscular dystrophy caused by titin. The difference in these forms, they're all caused by titin variants, but they might have a different combination of the symptoms and signs that we saw before. Often the onset is later on. You might have the distribution of weakness slightly different. In some people, the weakness is more distal, like in the distal myopathies. And the biopsies may be more dystrophic when you look inside the biopsy. In other forms, you may have, for example, in the limb-girdle forms, often the creatine kinase is quite high and the biopsy again is dystrophic. And in the Emery-Dreifuss form, you have more involvement of the joints. Probably all of these conditions are in a spectrum. So you have different combination of variants depending where the variant is, which part of the gene is involved, which part of the gene, where is expressed that part of the gene, if it's in the skeletal muscle, in the heart, explains why all people with titinopathy are different in the presentation. But then the condition is all the same group, but it's important to always identify the mutation and because of all the implication of having a mutation. And then we heard of that sometimes you have a variant that is of unknown significance, and then, as you mentioned before already, you might have to go back and do more investigation. And just to highlight again that this really often is a multidisciplinary approach to the diagnosis of people with titinopathy, because often it's not enough just to do genetics, not enough just to do biopsies, not enough just to assess a person in clinic. And you do imaging, you have to put all the pieces together, and sometimes you need somebody who's a bit more specialist, because it is often a bit more complicated to find the answer. And I would like, at my last slide, I don't think you can stress enough how important it is that when you get the diagnosis, and I know that in the US you might get the report, in the UK you do not get the report in your hand. The report is given to you by a clinician. That moment when you are told that you have a diagnosis or you may have a diagnosis is really important. So you have in that moment, is important that people are provided, and this is more a message maybe for us clinicians to do this when we give the diagnosis to somebody, it's an important moment that often families remember when they are told. And really it's important that we make sure that we give the right answers to families, or just say, honestly, we just sometimes don't know the answer, and that's okay, and we can explain what are the steps that are missing. Answer, provide information, leaflets, link to charities, link to association, give the people tools to where do you go from here, explain what happens now, and arrange next steps. So we have to do care. What is the care that we can provide? Even if we don't have cure, we can do care. And that moment of diagnosis has to be really an important step for the next step, which is referral to cardiologist, respiratory doctor, genetic counseling, and also to know what happens to the person from that point onwards. So I think this is really a key moment, and I hope that we will be able to provide more and more information to families when they are diagnosed. So that was my last slide. Thank you.
I'm in Philadelphia, so it's also interesting. And I actually did some sightseeing here already, so yeah. But anyway, so I work at the Folkhälsan Research Center, and Folkhälsan is now it's sort of going around here. Let's see if it's better here. I don't know. But anyway, so that's Folkhälsan is a foundation, private foundation, and non-profit organization that does put a lot of money also on research, and then we collaborate with the university. So I also have a university affiliation there, so I'm associate professor at the university. Anyway, so this is in Helsinki, Finland, and I showed this already last time, but not everybody was here, so I thought that it can be good to show where Finland is, because maybe somebody don't know, and it's up there. So squeezed between Sweden and Russia, but belonging to the EU. Yeah. And anyway, so this is how the institute looks like, but does this pointer work or not? No, all right, okay. But anyway, so I am here in the third floor of this building, and the Folkhälsan doesn't own the whole building. It owns one floor, one part of one floor of the building, quite big part. So there's place for 100 people there, but then the rest of the building is other organizations, the university, some other research organizations, some companies, etc. Then they have another building that they actually own, and that's where they do some health-related research, but that is not like this sort of molecular research, but more like lifestyle, etc. research. Anyway, so I just tell fastly that this started in more than 100 years ago, because there was this couple, Ossian Schauman and his wife Betsy, and they were quite wealthy, but they didn't have any children. And then I think they had seen that the healthcare didn't work very well, and there was not very much knowledge about hygiene and anything at that time in Finland, and then they started this foundation, and so that was quite good, and then very well kept, so it actually grew and became bigger and so on, and then they also wanted to start. So the society should use the remainder of the wealth to establish a maintenance of a Swedish, because I'm Swedish speaking, we're a minority in Finland, less than 10%, for theoretical and applied hereditary research, and that was pretty progressive in 1921, because nothing very much was known about that at that point. But anyway, so that's why they did, and that's why I'm here. So but anyway, then before I came into the picture was this guy, Bjarne Udd, that some of you may have heard about, and he had in the 80s and 90s, he's now retired, not retarded, something that was a bad saying. So retired, he's completely in a very good mental health, but anyway, so he saw a very peculiar muscle disease in Larsmo in Finland in the 80s and 90s, and it seemed to be dominantly inherited, But there was also these cases that were much more severe in the families. And then because Finland used to be, maybe not anymore, but used to be a isolate, genetic isolate, so sort of. So there are diseases there that are that are prevalent in Finland and not the other places, like you have in the Amish culture here in US. So and this disease was more prevalent in Finland than in other places. So it was belonging to a so-called Finnish disease inheritance. And then this was the disease, and you all know it already here. And he saw that this Tibial Muscular Dystrophy, it's recessive, so it's the dominant. But if you have it in a single dose, then the beginning is after 35 years. There's like 500 to 1,000 cases in Finland, which is a lot because we don't have that many people in Finland, like less than 7 million. So and then it affected the foot lifting muscles, as you know, and it causes atrophies of this tibialis anterior muscle. Then, but it's also that it was interesting in the way that there were these homozygotes that got the double dose of this disease in the family, a few cases there, and families, and this beginning in much earlier. It's all skeletal, but that is not exactly the truth. But because there have also been cardio symptoms and also breathing symptoms. But in the first case, it's not in all cases, and in the first cases, it wasn't seen. And at that point, now it's more than 10 cases in Finland also, but it was in the beginning something like this. And the patients are wheelchair bound from early adulthood. Of course, it varies from patient to patient, as you know. Oh, now it came. So, and then we began to, because we had done this so-called segregation studies, family studies, and saw that and you can sort of do these testings where you can make a linkage studies. I'm not going into that, where you can see in what part of the genome probably the gene is that has this variant that is causing the disorder. And in that way, it was narrowed down to a region where there was like many genes, but there was one gene in particular that was a muscular gene and seemed to be possible as a candidate gene, and that was Titin. As we know, that was the case. But as you know, that Titin is not the smallest gene in the world, so it's like 50 to 100 times bigger than the regular gene. And some of you have heard this story, so I'm not going through the long version, but through the short version of it. But anyway, so what we did, let's see if this works. Does it work? No. So we began the sequencing at the beginning of the gene. And because we did it with the Sanger sequencing method, which is like 100 times slower than the methods nowadays, so it was a lot of work. And we didn't go exactly like from 1, 2, 3, but we picked a little bit. But anyway, we went sort of through the whole gene, each and every exon. And then when we came to the last end there, and we hadn't found it, I was beginning to feel pretty desperate about this, and thought that, okay, now we have worked like 1 year in vain with this gene, which wasn't the correct gene, and so on. And then we sequenced the last exon of the gene, and there was the mutation then. So, but most of you know this story already.
You should have started from the other end.
Yeah, we should. And many told us that, but the point is that actually it was not bad that we did like this, because if we had started from the other end, okay, we would have found this mutation, but we couldn't have been sure that this really is it, that there's not anything else there. So, but I mean, of course, this was quite an obvious mutation, because it was not a single base pair change. It was 11 base pair where there was insertions and deletion and so on. So it was a complicated one. But anyway, we published that like in 2002, so that's a while ago. Time goes fast. And there is just this picture of how Titin works. So Titin is the yellow one there. So you can see the sarcomere in the muscle and then the other proteins. And I'm not going into its structure, but the function of Titin is to restore it when it has stretched like that. And then just a few words about this. So I mean, the traditional Sanger sequencing is also what you usually see in films, etc., that they have this pattern and so on. But and that well, but it was very slow and not always so reliable. And now we have the next generation sequencing methods, so you speeded it up hundreds of times. And now you can get the results in just like that, very fast. But of course the issue is that we have heard before here that the data is very big, that you get amount of data is very, very big, so it can be hard to analyze it. But however, that was some issue some years ago, but the bioinformatics have developed very much, so now it's actually not so difficult to filter out the relevant variants from there. And as we have you have heard before, I mean, there's the structure of a Titin, and you have many more than this. Is there some of them listed? This is an old picture, but anyway. But you can see one thing that in some of the cases, the mutations leading to a certain disease are sort of seem to be grouped in certain areas, especially these TMD-related mutations are there in the end of the Titin. But and of course this can be because there's different sort of functional sites and so on of Titin, so that's of course the reason. And then if you go into the variants of Titin, and one thing that you get this slightly repeated from what you have heard today, but I think that repetition is the mother of all learning, or whatever they say so here. But anyway, so the problem is that nowadays you find quite easily the variants in Titin, and that's fine, and you get the list. But of course, as we have heard before, the issue is to find which variant is relevant for you here. And this, of course, because Titin is so huge, like 50 to 100 regular genes, that means that the chance of any individual having a variant that is rare is quite big. So most of you will have a rare variant. Most of people in general will have a rare variant in their Titin gene and may not be related to any disease. And the other thing is that Titin is the structure is like a big thread like that. So that means also that a small missense mutation somewhere might not even cause anything, because so that means that it's sort of relatively resistant to small mutation in some of its parts, and that also makes it hard to say if something is actually causing something or not. And that's, as we have heard before, many variants have unknown significance and are called WUSSIs, and their clinical evaluation in diagnostic laboratories are sometimes very challenging to determine. And so you can say that Titin is certainly a special case when you compare it to other genes. So molecular method. There's one called alpha missense that is considered to be relatively reliable nowadays. And then I jump to so first of all, you can say that still about this diagnostics, that because all of this has developed very fast, the methods and also the bioinformatics, it means that it becomes more and more easy and reliable to diagnose titinopathies. And a lot of them can already be diagnosed, and I believe that in a very short time, or at least most of them will be possible to be diagnosed at least correctly. But then we come to therapeutic strategies, and that's another thing. I mean, that the therapeutics always lag somehow behind, some time behind of these, but there are two sort of leading approaches as far as I know. I'm not doing this sort of therapeutics, but those who are doing it, and one is this antisense oligonucleotides. You can do exon skipping, where you can skip some exons where you have commercially note patient-derived induced in stem cell-derived cardiomyopathies and in mouse models of the DCM of the heart disease. Maybe some of you know more about this side, I don't. So, and then the gene editing, including symmetric exon deletion and base editing, is proposed to correct effects with increasing precision. And I know that we have also used, we have used in for some other disorders, and it's good, but it's not that, it's a little bit tricky still to get it to function right and get the correct change there. At least we had some issues with that when we made zebrafish models, not of titinopathies, but of some years that it was tricky to have just the change you wanted there. But probably it has developed. Maybe Anna knows more about that. I don't know. No. But anyway, so they are developing, but they are not complete. We are not completely there yet in those. But then another thing that is coming very fast is artificial intelligence, AI, and that's something that people are afraid of because I mean it's something unknown and scary and so on. I think that it's probably like any new discoveries that if it's used correctly, it will benefit us. Of course, there are risks with it if you are not using it correctly or if it's used somehow in the wrong ways or something. But anyway, so that is helping us in the way that when you, for instance, have this for diagnosis, when you have these MRIs, for instance, they can be quite tricky to diagnose. I mean, let's say that Bjarne would probably say that it's not tricky, but many people would say that it is tricky to sometimes analyze them. But that you can use MRI for this, and it's been used already, so that you don't need to begin to look at yourself at all the pictures there, but you put this AI to use it, intelligence. So the tools are helping. It's one thing speeds up the process, and a significant role in the early diagnosis of NMDs. It can for data or relevant literature, and that is and it doesn't have the same sort of imagination and so on like humans. So you cannot always trust what it gets out from it. So you have still a human person has to be there and check that this is really relevant, but it can help there. And then you can integrate AI with genetic tools like all of this when you have the loads of the results and invariant detection, classification, and interpretation. And it has been demonstrated that it can help in classifying missense variants and reclassifying WUS, for instance, so that and so on. So it's possible to use also. And then it has been tried. There's also attempts to use it in therapeutics, and it will come more there for sure. And you can optimize, for instance, when you do these ASO sequences and chemical modification. You can use AI there to help you to do this. I'm not an expert on this. I have just read about it. Also for exon skipping applications, you have some programs as ESO optimizer, for instance, and so on. So you can say that artificial intelligence has significant promises for the field in the future. So conclusions that the first cause of first titinopathy or first titin gene variation that caused the mutation was found like 23 years ago. That's a lot of time already. And the titin, of course, is challenging to its size because most individuals have at least one rare or unique variant. And but I think that diagnosis for all or most titinopathies will soon be possible. And therapeutic aids are coming. of course, one thing is that they have to be tested. They have to do these clinical trials and everything, and that takes a lot of time. So even if you have basically, you have something that you think is working, you cannot begin to use it right away for the big public. The use of AI is increasing. So that's something to keep as a researcher in mind, that you should not be afraid of it. You should try to understand it and see if you can use it in your own research. And that's it. I just a list of the groups. So I listed the people only in the group that where I'm the co-PI. And then, but we have two other groups, and that is Marcos Savarese, who is sort of the administrative leader of us both, but we have this distinguished groups, and we are working as co-PIs. And then Katarina Pelin, who you might know also, who is working with nemaline myopathies. And I think this, I mean, it sounds like interesting, this that you have 3 persons leading a huge group, because all of these groups has about 10 people in them, so it's about 30 people altogether. But it actually works quite well because we are working well together, and we are not competing with each other or anything. So I think it works quite well. That was more or less it.
A-band and the M-line. Can you give a simple analogy of why is it divided that way? Where did the letters come from? Or, just so it makes sense in my head, why is it divided?
I haven't paid so much attention to that. I think that you mean this picture?
No, it's
I guess in general, the structure is divided in
Yeah.
Sorry. Yes,
Yeah.
yes.
Just like a really simple, what is the function of the difference between the A-band and the I-band, or why are those divided? Because I know where my gene is, right? I've looked at my report, I know what it is, but I don't understand what those divisions mean.
They are, I mean, it's because of the structure of the muscle and the sarcomere. So you have the set disc, and you have the M line in the sarcomere, and that's why they are called like that. And then you have these two A and I. Do you want to continue anything? You have a picture. So yes.
Can you turn?
Oh, hold on, you gotta switch it. Wait.
We need for them to answer.
Because this gene, the protein is very long.
It goes through the whole structure.
Yes.
Yeah.
An analogy is, or maybe you can imagine like a long, a long sentence or a chapter. Yeah. So you have there.
Yeah.
It's kind of small, but
So it's a bit like, imagine like sorry, maybe this analogy doesn't work, but imagine it, okay? So imagine that you have like a street structures in a city, and you have, the line, the avenues, and the streets, okay? And the Titin, imagine that these sections are where there are some lines that cross in the muscle. So the M line, the A line, the Z line, and when the protein was discovered,
Yeah.
these were the points where let's say these lines were crossing the protein.
Yeah.
And these lines are part of the muscle fiber that are important for function. So that's why they're called M line, A line, I line. But each part of the gene where your mutation is may have an effect on part of the protein, and therefore might be different if affects only the M line, which is the distal part, or the A line. And because some of the parts of the protein are not expressed in the heart, therefore it's important to know where your variant is.
Yes,
Does
and
this make
also
sense?
there are some unique areas in Titin that are in some parts of this, and in some parts are very just repetitive and not so unique, sort of. So I mean, you have there in the M line, in the end you have unique parts, and in the set line you have some and in them somewhere in the middle, but many of these are just very repetitive, similar. But actually, I mean, for instance, why the letter set? Do you know? I haven't thought.
Originally, I think
Yeah. Yeah.
like the structure of the muscle.
Yeah,
Like,
yeah,
I don't know why they
yeah,
said
yeah,
M
they
line
said-
or A
yeah,
line.
yeah.
No, A line maybe is the
Yeah,
actin.
yeah, yes,
M
that's true.
for
Yeah.
myosin.
Yes.
T.
Yeah.
Sorry, Z. I don't know. So
Yeah.
Z is the.
Yeah. Set disc, but
Is that
why
disc?
is it called set?
I think this is more
Yeah.
pathological or
Yeah.
long when
Yeah.
pathologically these were defined
Yeah.
like this in the line. When you look at the muscle in microscope, you see these lines in the electron microscopy, and they were
Yes.
called
Yeah.
A line, Z line, and then you discovered the Titin was in all of this,
Yeah.
and then you had
No
that
one-
part was
no,
in the M line.
Unfortunately, we don't have picture because there's many pictures of this.
Yeah.
So if anybody of us would have had one picture, we could
Yeah.
show how you see that it
Yeah.
looks like a zebra, sort of this. So these lines.
David had a question.
Yes.
Wait, let's use the microphone.
Sorry.
I think I can.
Okay.
As to your knowledge, where are we with gene editing? Is that something that we're hopefully looking at theoretically right now? Are there advances in that? Is that more of a not if, but when?
I would say it's when we are doing it already. But do you have any comments?
You know, if somebody asks me anything today, I'd rather be a little bit more on the, I don't like to give timelines that are too close because maybe you might give. Oh, sorry.
Yeah.
Is it better? Is that working? So I rather give a timeline that's a little bit longer in time, just because I think sometimes we give times and that does not happen. I think definitely we are closer now compared to where we might have been 20 years ago. Yeah, I think what is important is that everybody who has a diagnosis of titinopathy has the right genetic diagnosis, because it's very likely that you cannot do editing if you don't know if your mutation is at one of those VOSs, or it's always better to go back and say, okay, it was VOS 10 years ago. Can you tell me now, is it still a VOS?
But I would say that it's not like science fiction anymore. I mean, it's like we know that we will have it, but we don't know when. And it depends also on the length of these clinical trials and everything. So, yeah.
And may I also add something else?
Yeah.
That this is something that is quite being pushed a lot in other conditions that are more common, where already at the time of gene therapy, the care of the patient, of the person who arrives to gene therapy. So if your care is good and you get the right care and you are stronger by the time there is a gene therapy or editing or whatever therapy is, it's different compared if you are not accessing the same standards of care. So the response to therapy might also based on how you are. So it's very important that we don't just focus on novel therapies, but care management, clinical care, cardiac care. There is treatment for heart, there are medications for the heart, there are treatment for breathing, and it's important that we don't forget about this care.
Yeah.
That works.
And this treatment is also improving. So it's much better now than 10 years ago. Yeah.
Just a question here. Yeah. So can you explain about what's mini core, central nuclei, those very different?
Please, you can.
Okay, so these are something that you see when you do a muscle biopsy. And this literally what you see when you look at the biopsy. You have these very thin little slices of little microscopic slices of muscle, and then you look in the muscle and you see different coloration stainings that highlight changes in the muscle. And there are different. You saw the picture that put the different colors.
Yeah.
So there are different changes and structural changes. So the muscle can look differently. So first of all, each muscle fiber has nuclei, so it's where the genetic material is. And usually these are not at the center of the fibers, but usually on the periphery. And when you do the picture of the muscle, imagine it's a bit like a bunch of spaghetti, and you cut them, and then you have all these little circles, right? And those are the muscle fibers. The muscle fibers are long, you cut them like this, and you have all these little spaghetti circles, yeah? Usually the nuclei are not in the center, but that's in a healthy muscle. And often in myopathies like titinopathies, you might see that the nuclei, this darker point, is in the center. So that's often what you see by central nuclear myopathy. So that's the first thing that you see. And then there's another staining where you look at how many at the oxidative content of the mitochondria. Anyway, it's a different staining, and often you might see again structural changes. So the coloration is missing in some parts of the fiber, and they look like cores, like holes in the staining, like the staining didn't color that part. And sometimes in titinopathy muscle, you see that there are a lot of little holes, so mini cores, so multi-mini cores. Yeah, so the blue line in the middle, the N, you can see that there are a little bit of different colors. These are little tiny pictures, you might not see that much. However, you may not have a biopsy, so you might not know what is in your muscle. So if you have it, you might have that information. If you don't need the biopsy, it doesn't really matter. At the end, the important is that you have the right diagnosis.
Does it change over time?
May change over time. That's right. So sometimes you might see that but no, usually we don't do biopsies at different ages because it's very invasive, in particular a young child. But you might see that in some myopathies, you see that when the children are little, they might have more cores and then more central nuclei, and then but we wouldn't do it. It's important for diagnosis, but you don't need it.
Maybe doing a muscle biopsy.
Hold on, let's use the microphone because of the recording. Then people on recording can hear.
I'm not sure if this is on actually.
Yeah.
I'm not sure if that's
Yeah,
on.
it wasn't, I think, in before. Yeah. Yeah.
Then we can have two handhelds.
Yeah.
They both can't run at the same time, unfortunately.
So my question is a follow-up to the question on the gene editing, and it really has to do with the gene therapies on Titin. Is there anywhere I know that there's a lot of theoretical and academic research that's occurring, but is there actually any research that is occurring on gene therapies related to Titin? And if so, where is that? It's been very hard to find that information anywhere.
I think first of all that it's farther about the cardiomyopathies than about the skeletal muscular disorders, and it's done, but I don't know what groups are working on it. We haven't.
I'm not aware of anybody actively working on. I think the biggest issue is that the vector gene therapy, you need a virus.
Yeah.
So I don't know if anybody else wants to comment or.
Yeah.
But,
No.
But so the virus, you use a like a virus that doesn't cause harm. You put the gene inside, the virus goes in your body, and Titin is big and it doesn't fit in there. So you need to make it smaller. So perhaps you could think about creating a mini Titin that only gives a specific part of the information. So perhaps this is something that is being developed for the heart, but I'm not aware of. From a skeletal muscle point of view, this would be very tricky. So I think we're more talking about like exon skipping or CRISPR, like when you try to take out the change.
Yeah.
More than gene therapy.
Maybe just to add to that, the field of gene therapy, or sort of the gene modulating, that's rapidly evolving.
Yeah.
So we're still learning as we're going. So like, let them figure it out for other things.
Yeah,
It's the
exactly.
same technology, right?
Yeah.
For one
So-
disease versus another disease, it's the same technology.
As it's rapidly evolving like that, I think there was a question earlier about the resources that are available. And I understood the question to be more about resources that are available that as patients, my children both have titinopathies that are manifesting themselves differently. So are there resources available to be able to educate the healthcare professionals that they have? That's the thing that we challenge with the most. That's the reason that we've had so much trouble with getting family-related genetic testing, not because of the family members, but because of their healthcare professionals. Is there a consolidated resource or even a resource that's available, sort of like what the Speak Foundation put together in the Family Resource Guide for limb-girdle muscular dystrophy? Is there anywhere that we can point the healthcare professionals to help educate them about the disease?
Well, that's one of the goals of our organization. I can speak to that. It's
So when you're faced with a rare disease, it is difficult for people to find resources, and that is one of the roles of Team Titin. And one of our goals is we have information on the website. We have the care guidelines, which apply, like when Anna's talking about care for breathing and all the functions that we have the care guides, both for the care guides for the myopathies, which is on our website, and the limb girdle care guide, which is just published and free and available. And then for standards of care for cardiac care for Titin-related conditions, generally follows the standards of care for other heart conditions, and we're going to hear more about that very shortly. So that is, and we have been working to broaden our information on our health conditions in the form of NORD, the National Organization of Rare Diseases. And we have 2 web pages that Anna and and Jennifer and helped to put that information together to make it more searchable. So the national, and Anna had that on her slides, which was the National Organization of Rare Diseases. There's 2 pages, one on recessive titinopathy and one on dominant titinopathy. We had an older version of that, was on recessive titinopathy, and we sort of sunsetted using that when we just got the recently updated. So, and by the way, this is not unique to Titin, and I know some of the cardiologists who are speaking next that came in the room, and that if let's say there's an inherited cause of about 50% of cardiomyopathies, and about 1% of people get genetically tested. So that when you talk about the field is evolving, the field of people thinking about genetics and testing for genetics and understanding it and how do you apply it to a specific standard of care is an evolving field. And so that's a common problem across common conditions, but it's also a particular problem for us. But you raise excellent points. And so we tried to do things like have a website and get a Google ad grant, so when people put in our search terms, that we could pop up for them, and other types of things to spread the word. And you guys coming here, but it's definitely a challenge, and self-advocacy is required. Let's admit that. And all of you who are here are probably awesome self-advocates. That's how you made it here to this kind of conference.
Maybe I could add there that which we talked about yesterday. There also that one issue is that it can be difficult to get fundings for rare disorders because they are rare, and that's why it's difficult to get the funding. But in the case, for instance, of muscular disorders, the thing is that if you find out results and so on about one disorder, that can aid in finding therapeutics or diagnostics for others as well, and that's one good argument to why you should fund rare disorders. So that's just one point.
First off, thank you guys for coming a really long way to talk to us here. This is great. Question for me is, so what is the level of evidence required to get a variant of unknown significance classified as a likely pathogenic variant?
So I mean, first of all, you can use, of course, these prediction programs and so on to see if it seems like causing anything, but then it's good to find it in some other person, maybe even unrelated. I mean, not knowingly related, who have the same disorder. And then one thing is that you would like to see if it segregates with the disease. So if you sort of have a family tree of the family that has this disorder, and you know who is affected, then if you have the possibility to get samples from all these people and from the others, then you can see that does it really occur, this disorder, in all the members that have this particular variant. So that is one way to do it. But then also you have all these functional tests, so you can, first of all, it's good to have a biopsies if possible, and that in skeletal muscular disorder, it's of course easier, but if you have a cardiomyopathy, you cannot take easily a biopsy of the heart, of course. But if it's a skeletally expressed disorder, then you can get these biopsies, and then you can study them, and you can look at the changes on the RNA level, that is it expressed, first of all, the change. Then you can look at the protein level to see how it affects the protein, if it's truncated or different or something. And then you can you can also you can use cell lines to see how they act and so on. So there's many different ways, but you should have more than just the fact that you have found a rare mutation in a gene is not enough usually.
Yeah, of course. But I guess with all the clinical correlation in the world, you have one that's variant of unknown significance. Like, what's the pathway at that point?
So exactly, that's the pathway. So if you do have a variant of unknown significance, then you have to go back to the phenotype and to the patient and to the family and do all these steps. The importance is that you don't just discard them, because this is also why it's important that the laboratory, often, that they don't, sometimes some variants may not be reported because maybe the symptoms that were written on the referral form does not include that sign that is usually associated. So, but then you have to go back, so the clinician should then do the investigation to prove. Sometimes you need to do some really basic science tests, so like functional tests, research tests, because it's complicated to prove that change causes something. It's not a written, like a published, like you have to do step 1, 2. It depends on the change, depends on what type of change it is.
Yes.
Does this answer your question?
Kind of. I mean, it seems like it's also dependent on the lab. Is that right? Or
Yes, and in this country, the labs follow published guidelines for variant interpretation that are published by the American College of Molecular Genetics and the American Molecular Pathology Association. And it's very strict, and there's a point system, and some labs have a little bit additional layers of, evidence that are required before they will reclassify a variant. And the reason is that they don't want to be wrong and tell someone they have a pathogenic variant when it's actually not. Sometimes they'd rather err on the side of caution. But in cases like that, you might be able to work with your genetic counselor or medical geneticist. This is very specific to genetics in this country. And you might be able to get them to call the lab and review what evidence has gone into that classification. And these guidelines that we have are likely to change with time. In fact, I think you're working on new variant interpretation guidelines, and they are particularly limited when it comes to a gene like Titin, which has all the challenges we discussed today. So while it might be frustrating, you might be able to work with your clinician and just kind of accept, we're going to treat this as a pathogenic variant for the purposes of our medical care. And if it's, if we can't get the lab to change their mind, we just might have to wait for them to catch up. And that does happen. This is a dynamic situation, and particularly with Titin, these variants can get upgraded from uncertain to pathogenic with time. And we've seen that over the last 12 to 24 months in Titin.
Just to add on that, is that this is not unique for Titin. So the doctors who see muscle conditions that are genetic, and if the variant is considered a VUS, and the lab cannot upgrade it, the doctors who know neuromuscular conditions should know what can you do next to help to push it up.
Yes. Then one important thing that we sort of mentioned is the databases, that there's a lot of worldwide databases where you can check if there's some other knowledge somewhere about this variant, or how usual it is in different populations, because different populations differ very much. So something can be usual or unusual in different populations. So that is one thing. Another thing that is important is the collaboration between different groups, because there's no such groups that could do all of these things alone. So you may find something and you cannot be sure if it's true or not, and then you would like to do some certain functional tests, but you don't have the possibility there. But then you might know some other group in some other part of the world that can do that. And if you collaborate, you can together, you can by using them, and it's both sort of gains from it.
Well, we need to finish up on that collaboration note. Team Titin hosts 2 times a. Okay. We are going to need to finish up, but I'll do one more question. But I just wanted to say about collaboration is Team Titin hosts it twice a year international case conference where people bring complex cases looking for variant clarification and diagnosis, and also research updates. And there has been cases where somebody presents a case and somebody in the group says, I have a case like that, and I have a case like that, and then next thing you know, you have 3 cases like that. Or so we're trying to build momentum, building the databases, enhance collaboration and working together, which is, by the way, how this diagenic cause of titinopathy emerged, was through curiosity, persistence, and a lot of collaboration, and like really smart people who really, we appreciate that they went that way. So we'll just take one more question. We're going to wrap up. We're going to have just a couple of housekeeping items. We're going to have our group photo next in this room, and our photographers are here, and we're going to have our refreshments in this room, and then our next session starts at 4. So we're going to just take this last question and move on.
So first, I want to thank you, Sarah, because if Sarah wasn't around, none of this would have happened. So the idea of bringing together the scientific community and the family community is for you, Sarah. Also, I guess it's a flag / a question, and this may date back to an email that I will follow up again with Sandra, who has to deal with all my emails. Gigi's variants are classified differently. And so the question I'm left with is, how do I figure out what's correct? Mostly because folks keep saying, I keep hearing, you have to know specifically what your diagnosis is. Is it enough to know this confusing mix that we have of what we think the classification might be depending on international databases? Or should she get this done again so that we can have one clear, this is where the variant is?
Maybe Sandra should answer that one.
Sorry.
I'll respond again to your email. Happy to. No, so initially, the Titin's very complicated, as we always go back to, and the Titin sequence that was used 15 or maybe 10 years ago, I don't know, about 10. Yeah, the sequence that was used back then in the commercial labs is different from the sequence that's used now. Yeah. But we're able to make we know old sequence, we know new sequence. So if a report has an old sequence, and someone that's fairly comfortable looking at genetic testing reports knows to look at, this is Titin, and it has a number. It has NM dash whatever number. That number reflects whether it's old sequence or new sequence. Yeah. So if it has the NM dash number there with the location, anyone that's decently savvy can convert that to what the new sequence is. So you just it has to be listed on the report. If I were to send testing now, it would give a report, new sequence, MN number. The variant location looks different, but if you do the conversion, it's the same.